Hello everyone, my name is LalkiyaD and I'm a research assistant in Department of Urology. Our today's topic of presentation is artificial intelligence modeling for prediction of renal cancer recurrence, a systematic review which falls under theme 2, biomedical and medical sciences. Disclosure of affiliations, financial and in-kind support. I have no relationship with for-profit or not-for-profit organizations. This session's program has not received any financial or in-kind support. So today I will be sharing the highlights from our recent systematic review on the use of artificial intelligence technologies to predict the renal cancer recurrence, a growing and promising field in urological oncology. Renal cancer is a significant global health concern. It ranks as the sixth most common cancer in men and 10th in women worldwide. Despite surgical treatments, recurrence occurs in 20–30% of the patients, and over 40% may ultimately die from the disease. This sobering statistics points to an urgent need for more precise, personalized monitoring tools, and that is where AI may hold real promise. Our review aimed to synthesize the current evidence on machine learning models used to predict the renal cancer recurrence. We searched 6 major databases including the PubMed, Embase, Scopus, and Google Scholar, covering literature up to January 2025. Out of 143 initial citations, only 4 studies met our inclusion criteria. Although small in number, these studies offered important insights. Collectively, as an finding, they employed 10 machine learning algorithms ranging from naive Bayes and decision trees to adipose and random forest. Each model was trained using 7 to 10 clinical and pathological predictors. This included variables such as age, gender, smoking status, BMI, tumor size, histological type, Fuhrman's grade, and type of nephrectomy. Notably, all 4 studies used area under the curve as the main metric to assess the model performance, with AUCs ranging from 0.740 to 0.877. This indicates a moderate to high level of diagnostic accuracy. One particularly robust study from Korea demonstrated an AUC of 0.836 for predicting the recurrence within 5 years post-surgery. Another study by Geo et al. Reported an AUC of 1.877 using a boosted decision tree model trained on data from nearly 700 patients. Across the board, random forest and adipose emerge as strong contenders in model performance. We also assessed the study quality using the robust tool. 3 studied had a low risk of bias, while 1 had a low to moderate risk, suggesting relatively good methodological soundness. In the broader context of renal cancer care, AI is showing potential not only in recurrence prediction but also in tumor grading, staging, metastasis detection, and survival estimation. Studies have reported AUC as high as 0.96 when using AI to differentiate low versus high-grade tumors, and around 0.83 when predicting metastasis from imaging data. However, there are limitations. The number of studies specifically addressing recurrence prediction is still small. Furthermore, many models lack external validation, which raises questions about generalizability. There is also concern over positive bias in algorithm development, especially in competitive environments without independent replications. Going forward, interdisciplinary collaboration is a key. Clinicians, data scientists, and AI developers must work together to standardize data sets, define clinically meaningful endpoints, and establish best practice for AI deployment in real-world settings. Incorporating AI educations into medical curricula will also be an essential as these tools become more embedded in clinical decision making. In conclusion, AI holds significant potential to improve how we can predict and manage renal cancer recurrence. While early results are encouraging, the journey towards widespread clinical application will require rigorous validation, large-scale datasets, and careful integration into existing healthcare workflows. Thank you everyone for your time. That's the end of my presentation.